Hi, my name is Christopher Alabi. I'm a first year internal medicine resident from the East Florida GME program, training at the Westside Regional Medical Center and the Northwest Medical Center in Florida. Today I'll be presenting a case of warm autoantibodies resulting in a transfusion reaction in a setting of ANCA associated renal failure. Introduction. ANCA associated renal failure and the presence of warm autoantibodies are two different and fairly uncommon pathologies without any known connection, especially because the cause of each one is so far not well understood. This is an uncommon tandem of ANCA-associated vasculitis and warm antibody autoimmune hemolytic anemia. Case presentation. A 79-year-old retired lady presented to the ED with gradually worsening fatigue, anemia, and was found to have a new onset renal failure. Her past medical history was significant only for hypertension, well controlled on medications. There were no abnormalities found on review of lab results done as an outpatient 3 months prior to her presentation. Physical examination and admission was significant for conjunctival pallor without jaundice, and her pertinent laboratory findings included an elevated BUN, elevated creatinine, anemia, hematuria, and mild proteinuria. Additional laboratory findings revealed a positive Coombs test, positive p-ANCA, and warm autoantibodies discovered during blood typing and cross-matching. She had a mild self-limited fever and back pain within 15 minutes of transfusion of the best matched packed red cells, and this necessitated stopping the transfusion. Her renal biopsy revealed post-immune crescentic glomerulonephritis, while bone marrow aspiration was normal and anti-glomerular basement membrane antibody was negative. She was subsequently treated with cyclophosphamide, steroids, washed red blood cell transfusions, IV erythropoietin, and courses of dialysis, which continued after her inpatient management. Figures 1 and 2 are microscopic slide images of her renal biopsy results on light microscopy and electron microscopy, respectively. Discussion. The prevalence of crescentic glomerulonephritis ranges from 1.56 to 10% of total kidney biopsies reported by a large national kidney biopsy registry, and it is characterized by rapidly progressive renal disease as seen in this patient. On the other hand, autoimmune hemolytic anemia is only seen in about 1 to 3 persons per 100,000 per year. Consequently, a transfusion reaction attributable to preformed warm antibodies is an uncommon occurrence. Both conditions have immunogenic pathophysiology. However, the correlation between them is yet to be explored. Literature search has not revealed case reports of contemporaneous disease activity in a single episode of illness. Glucocorticoids and cyclophosphamide or rituximab remain the recommended first-line initial therapy for severe ANCA-associated vasculitis, with overlap efficacy for autoimmune hemolytic anemia. In conclusion, our body of knowledge on the contemporaneous disease process of ANCA-associated vasculitis and warm antibody autoimmune hemolytic anemia is limited. Therefore, this unusual pairing in our case may serve as basis for further study. Thank you very much for your time and have a nice day.